It's Friday the 13th. That's in May of 2016. And this is the RheumNow Week in Review. Hi, I'm Jack Cush, Executive Editor of RheumNow.com. This week's postings of news and journal articles from the RheumNow social media feed includes a report from the Brigham and Bonnie Burmis's group, a retrospective study of their lupus cohort that was and pregnancy, wherein they specifically looked at outcomes of pregnancy and predictors of poor outcomes, namely preeclampsia, preterm birth, miscarriages, stillbirths, etc. And they showed in their retrospective study of their cohort that the presence of nephritis, cytopenia, and serositis during the pregnancy were predictive of these poor pregnancy outcomes. Reinforces some of the information we already know about lupus and the difficulties of managing lupus during pregnancy. Interestingly, there was a French study that included almost 1,000 patients, part of the ORA registry. This is a registry of patients going on abatacept for rheumatoid arthritis, and they specifically looked at serious infectious outcomes. They found that the predictors, after multiple adjustments, the predictors of an SIE event with abatacept was a prior history of an SIE, such as a prior history of pneumonia, prior history of cellulitis, etc., and advancing age. Two things that have borne out in other studies that show up here. Abatacept has a fairly good profile with regard to serious infection risk, and this better defines maybe those who might be at risk when receiving this particular biologic. An interesting teaching point in a small report from the New England Journal this week is the chewing gum test. Two reports were outlined where the investigators would give their patients who either had giant cell arteritis or who had suspected giant cell arteritis and gave them chewing gum and asked them to chew it, 1 chew per second. And when they could produce claudication and pain after 2 to 3 minutes, that tended to be predictive of histological and clinical evidence of giant cell arteritis. In one case, a recurrence of giant cell arteritis. In another case, a diagnosis of giant cell arteritis in someone who had a normal sed rate but a suspicion of GCA. So the chew gum test could be something that you could do while the patient's filling out the forms. A population-based study in Taiwan of over 40,000, not quite 40,000, 34,000 patients showed that gout has a higher association with depression. Find that surprising because you wouldn't, we know that certainly occurs in psoriatic arthritis and maybe with chronic diseases, but an intermittent inflammatory disease or a disease that may actually have substantial social stigmata associated with it, gout nonetheless is associated with depression in their population-based study. Interestingly, they showed that patients who were effectively treated with either prednisone or urate lowering therapy, that association went away. So maybe there's something to that. Another report, we've seen this before, but a report confirming that the association with urate lowering therapy and lower risk of cardiovascular events was again reported on the website. A report from Australia looking at a survey of primary care physicians and house officers shows a wide variety of answers when it comes to how you diagnose, how you use colchicine, how you use urate lowering therapy. So again, the practices for the diagnosis and treatment, especially with regard to colchicine and monitoring, were quite disparate amongst these two groups and not really in line with the ACR guidelines on gout management. Lastly, there's a study of elderly people on biologics and what happens to them. It's a review largely based on secondary analyses from the literature, and it shows that, one, biologics are as safe in the elderly as they are in younger people, with the exception of a higher risk of serious infection that is age-related. The efficacy is roughly the same, and this study was mostly on TNF inhibitors, but did look at other biologics where they had the same time on drug and withdrawal rates as a measure of safety. Maybe they had, with the TNF inhibitor studies, a little less responsiveness compared to their younger cohorts, but nonetheless, efficacy was certainly still there. Several important news features from this week's RheumNow included a review of a number of cases covered in something called curbside consults, wherein we looked at 3 specific cases. one that had a well-controlled case who developed a melanoma in situ and what to do about that. My response was melanoma in situ has no risk of progression, invasiveness, or malignancy like malignant melanoma. Hence, you can continue to use a biologic and a TNF inhibitor. In that case, the patient was on a TNF inhibitor and hydroxychloroquine. And the physician was asking about what alternatives should be used in the case of melanoma in situ, and my answer was none. You're doing very well with that therapy. You don't need to change it. But it does bring up the issue of when you do change and what you should change to. The ACR guidelines are quite unusual in my opinion, in that they recommend that you should, in the case of cancer, and of course they consider 3 different kinds of cancer situations: a solid tumor, a lymphoproliferative malignancy, and skin cancers. But in general, they say you should use DMARDs and combination DMARDs before you use biologics. And that if you're going to use biologics, that you should use the non-TNF biologics first. That includes rituximab, abatacept, and tocilizumab before a TNF inhibitor. And I disagree totally with those ideas. A DMARD versus a biologic, yes, maybe a DMARD, if you can get away with that, that would be a good choice. But if you have to use a biologic, there's far better data for the use of TNF inhibitors in the setting of malignancy than there is for rituximab, tocilizumab, and abatacept, where the guidelines are based on, admittedly, and they say in the guidelines, this is very weak evidence, and really based on expert opinion. I don't think that they had the expertise on that committee to really answer that question. My opinion, but I would use a TNF inhibitor if I had to. This patient was on a TNF inhibitor, all as well. The second case was a case of RA not responding who had problematic liver enzymes. The teaching point here was, of course, work it up, get a biopsy and an ultrasound if needed. In the case of liver disease, there are certain drugs that can be safely used in rheumatoid arthritis, and that includes prednisone, gold, hydroxychloroquine. Lessons learned from the transplant literature would tell us you can use cyclosporin and mycophenolate, marginally effective in rheumatoid arthritis, and you can certainly use a TNF inhibitor and or anakinra in patients who have liver disease. You do need to worry about the risk of reactivation of hepatitis B if that's a possibility. It's been well described in patients receiving rituximab. It's also been described in patients receiving TNF inhibitors, especially infliximab. So, and the last case was a case of a patient who had interstitial lung disease and what therapies should be used in the setting of RA and interstitial lung disease. Again, I don't know why people worry about using methotrexate here, because methotrexate causes a hypersensitivity pneumonitis. It is not proven to cause a chronic interstitial lung disease, RA lung, which is progressive and deadly. There are a number of erroneous reports, mainly from Japan, linking ILD to a number of drugs, including methotrexate, leflunomide, TNF inhibitors, and even other biologics like Actemra. But again, that data is very skewed and really not worth considering. Certainly, if someone has very, very bad lung disease, you might not want to give a drug that could cause hypersensitivity pneumonitis like methotrexate. But the use of to say that someone cannot get these therapies when they have ILD at all is probably a bad service to the patient. Usually that patient's going to have severe disease. They're going to need aggressive therapies. And if you're not able to use your best therapies because of these sporadic reports that really are not borne out by systematic analyses or repeat studies, I think would be a bad thing for the patient. So consider other options there. There was another interesting report on patients with scleroderma who have digital ulcers. Was a report of the Dual 1 and the Dual 2 trial, which looked at a macitennan, which is an endothelin receptor antagonist, so basically blocks the activities of endothelin 1. And 2 very large trials, a total of 554 patients. The problem is that they did not meet their primary endpoint, which was new digital ulcers. They were not able to show that point. So this was a failed trial in that ulcer scores and new digital ulcers on drug versus placebo were not any different. The problem may have been in the trial that there were not enough new ulcers in the cohorts analyzed, where they averaged about 1 new ulcer per patient. This is a bit disquieting, especially in light of the SEDUCE trial, which is about to be republished in Annals of Rheumatic Disease in June of 2016, which shows that sildenafil, Revatio, Viagra also failed to show clinical benefit in treating digital ulcers associated with systemic sclerosis. And the last report comes an interesting and important report, and maybe a major advance in rheumatology if it's borne out, is the FASCINATE study, which tests the efficacy of tocilizumab in patients with systemic sclerosis. This was an 87-patient, double-blind, randomized, placebo-controlled trial, and it was a 2-year study. The first major time points were 48 weeks, where the primary endpoint was a reduction in modified Rodnan skin scores, and they did not meet that primary endpoint. Patients on tocilizumab were not significantly better than those on placebo. However, at 48 weeks, they were better than placebo as far as the modified Rodnan skin scores, and they also showed less decline in lung function measured by FVC. So this is a potentially new therapy and a new approach to a disease that doesn't have effective therapy. We await the results of a trial that's currently enrolling, a much larger phase 3 trial that will look into the efficacy and safety of tocilizumab. Again, until it happens, we don't know. At this point, you shouldn't run out and start using tocilizumab in patients based on this data, because it did fail its primary endpoint in a relatively small 87-patient pilot trial. But nonetheless, this could be an important new advance that we should be tracking. So anyway, that concludes this edition of the RheumNow Week in Review. For the links and citations that we mention here, you should go to the website and download those, look at those. You can also look at the video at the website under the video tab or on YouTube. And lastly, you can listen to the podcast of this Week in Review and others by going to iTunes and downloading them. So be sure to tune in to the wonderful, exciting world of rheumatology at RheumNow. We'll bring you the news. Take care.